Yeah, thank you for this very kind introduction, and thank you very much for the invitation. It's a great pleasure to speak in front of a parterre of pharmacists and nurses, so I'm very honored. And today I will be talking about drug-drug interaction and supplement use in older adults with HIV. So what I plan to do in the next 20 minutes is to cover drug-drug interaction that are of interest with modern antiretroviral therapy, including drug interaction with supplement medicine. And then, because with aging people, there is physiological changes, you will see that in older individuals, there are other issues than drug-drug interaction that I would like to point out. And I will also briefly discuss on what are interventions that we can do to prevent polypharmacy, unnecessary polypharmacy, and prescribing errors, and I'll finish with a case. So why do drug interaction matter? So as we have seen in the previous talk, the population living with HIV is aging. And with aging, there is an increased number of comorbidities and an increased number of co-medication, which can increase the risk of drug-drug interaction. So you can see here 2 cohort studies in which the use of co-medication was analyzed. Please note that the median age was 50-year-old and older. So one cohort was the Swiss HIV cohort. It's an analysis of almost the whole cohort, more than 9,000 individuals. And you can see that with aging, there is an increase in the use of co-medication and particularly an increase in cardiovascular medication. You can see a similar picture in the Danish cohort, and what is interesting in that cohort is that they didn't only look at medication that are prescribed, but at all the medication that individuals were taking, including over-the-counter medication, and also supplemental medication. And you can see that quite a substantial number, 56%, was using supplement, particularly vitamins. So we know as healthcare provider that drug-drug interaction are a concern, but I like to say that this concern is not only shared by us, but also by people living with HIV. And this is actually a survey in which people living with HIV were asked what are the most important characteristics of new antiretroviral drugs. And you can see that drugs with a lower potential for drug-drug interaction comes up as one of the top priority. So let's see briefly how drug-drug interaction can occur. So drug-drug interaction can occur at the level of absorption. You have different mechanisms. So one mechanism that is particularly important with integrase inhibitors is the chelation with divalent cations. But interaction can also occur at the intestinal and liver site due to inhibition or induction of drug metabolizing enzyme or drug transporters. And finally, drug interaction can occur at the renal level due to inhibition of drug transporters. And you can see here the drug interaction profile of several antiretroviral drugs when considering more than 1,000 medications. So basically the medication that we have in the Liverpool HIV drug interaction website. And you can see that unboosted integrase inhibitors, the doravirine, the long-acting antiretroviral drugs have a lower potential to cause clinically relevant drug-drug interaction, which are basically the amber and red one, compared to protease inhibitors or NNRTI from the first generation. And I like to mention this study. It's from a Canadian cohort, which shows that in the recent years, there is actually a lower use of boosted protease inhibitors, and in parallel, you can see that the use of unboosted integrase inhibitors increases, which has as a result to reduce the prevalence of potentially clinically relevant drug-drug interaction as the use of unboosted regimen becomes more important. And these observations are also supported by this other study, which looked at the prevalence of potential drug-drug interaction when switching from a boosted containing regimen to a bictegravir or dolutegravir containing regimen. So you can see that changing to unboosted integrase inhibitors will actually reduce the risk of drug-drug interaction, notably with cardiovascular drugs. But on the other hand, switching to integrase inhibitors will increase the risk of potential drug-drug interaction with mineral supplement or like, for instance, magnesium, calcium, iron, or metformin. So it is important to highlight, probably you heard it today, that one of the key interactions that we have to be aware of with integrase inhibitors is the interaction with divalent cation, which can form a complex at the level of the gastrointestinal tract so that the integrase inhibitor is not absorbed as well. And you can see here the effect of this type of interaction, which will result in a substantial reduction in exposure of basically all the integrase inhibitors. And I'd like to mention an open access website, which you can consult either to report real-life drug-drug interaction cases with the outcome as observed in real life, or that you can consult to have an idea of whether combining two drugs can lead to a deleterious outcome. And when looking at this website and searching mineral supplement, you can see that there is several cases that led to a loss of efficacy, particularly when combined with integrase inhibitors. And when looking a bit more closely to the cases reported in the website, you can see that there are several cases of deleterious outcome, either represented by a reduction in efficacy or a toxicity. And some of these cases were due to the use of over-the-counter drugs. So this data indicates that it is important to actually ask about non-prescription drug when reviewing the medication in order to prevent unwanted adverse outcome that would be due to the use of over-the-counter drugs or herbals and so on and so forth. And this is particularly important because, as you know, the drug-drug interaction with a mineral supplement or antacid that contain divalent cations are totally manageable, and you can prevent this drug-drug interaction. So it's important to know what individuals are taking. And another interaction that came up as potentially more prevalent when switching from protease inhibitors to bictegravir or dolutegravir was the interaction with metformin. You have to know that metformin is eliminated in the urine via renal transporters, OCT2 and MAT1, which are inhibited by bictegravir and dolutegravir, and this will increase the exposure of metformin, and this can raise, the concern about an eventual development of lactic acidosis. But actually, when looking at the literature, metformin-induced lactic acidosis is rather rare. It has been reported in relation to other underlying condition, and the risk is usually increased in individuals that have an impaired renal function and when using high doses of metformin. So for bictegravir, there is no need to adjust the dose of metformin in individuals that have a normal renal function. A dose adjustment may be considered in case of moderate renal impairment. And for dolutegravir, you need to monitor and consider dose adjustment when starting or stopping dolutegravir, avoid high doses of metformin, and there is also some guidelines that restrict the daily dose of metformin to 1 gram. However, I would like to mention there was a study that was presented last year at CROI that shows that you could actually have subtherapeutic concentration of metformin, particularly in obese individuals that would be on dolutegravir. And really, when looking at modern antiretroviral treatment, the drug-drug interaction that remain problematic are really interaction with inducers. You can see, for instance, that with a strong inducer like rifampicin, you cannot co-administer a lot of the antiretroviral treatment, with the exception of dolutegravir and raltegravir. You would have to double the dose of the antiretroviral drugs. And for moderate inducer, you can actually give together with doravirine, rilpivirine, but you would have, again, to double the dose of these antiretroviral drugs. But there is no recommendation to use, you cannot use it with bictegravir or a long-acting antiretroviral agent. And it is also important to remind that giving an antiretroviral drug intramuscularly or subcutaneously does not eliminate the risk of drug-drug interactions. So you will eliminate the interactions that are occurring at the level of the intestine. So for instance, for cabotegravir, you don't have, with oral cabotegravir, the interaction with divalent cation, or rilpivirine, you don't have the interaction with inhibition or induction of enzyme at the intestine level. But once the drug is absorbed, then it can be subject to inhibitory or induction by concurrent drugs, like for instance here with rifampicin. And you can see actually that giving the drug, like in this case, cabotegravir and rilpivirine intramuscularly, will not necessarily mitigate the magnitude of the interaction. For instance, you can see that oral cabotegravir exposure is reduced by 59% in presence of rifampicin, and when you give it intramuscularly, you see a similar reduction in cabotegravir exposure. And what is also important to note is that with aging, you have various physiological changes which can actually impact the pharmacokinetic of drugs. So you have an increase, a reduction in the liver mass, in the liver blood flow, a reduction also in the renal function. And when looking at the literature and studies that evaluated the pharmacokinetic of antiretroviral drug in elderly individuals, you can see that overall these physiological changes translate in an increase in exposure for most of these antiretroviral agents. However, to an extent that is not considered to be clinically significant, so a priori, there is no need to adjust the dose in absence of severe comorbidities. Looking at intramuscular cabotegravir and rilpivirine, so this modeling study showed that there is a predicted increase in cabotegravir and rilpivirine exposure of 26 and 41%. In elderly compared to young. And again, it's given the good tolerability, there is no a priori need to adjust the dose of the long-acting cabotegravir and rilpivirine in elderly individual. But with aging, you have also other changes, such changes in the affinity of drug to receptors, which can actually modify the effect of a drug. For some drugs, there can be an increase in the effect of the drug, which can actually increase the risk of adverse effect. And you can have also some changes in some of the homeostatic physiological processes. And maybe one effect, because you were talking about neurocognitive impairment, that I would like to highlight is that elderly are more sensitive to adverse anticholinergic effect. And this is due to a decrease in cholinergic receptor in the brain. So that drug with anticholinergic properties can impair cognition and increase the risk of fall and frailty. So we did an analysis of the Swiss HIV cohort, and we found that actually the use of drug with anticholinergic properties is quite common. 20% of elderly individuals were receiving this drug. And we found that there was a trend with being on one or more than one drug with cholinergic properties and self-reported neurocognitive impairment. And also, a drug with anticholinergic properties have been associated with motor skill deficit. And I like to mention this analysis of the UK POPI cohort, which found that for individuals on drugs with anticholinergic properties, there were higher odds of recurrent fall. Also, frailty was more common in individuals on anticholinergic medication. So you can see here some example of drugs with anticholinergic properties. So you have antidepressant, but also drugs that you can use for urinary incontinence. And when you evaluate someone that has a neurocognitive impairment, you should also think about the medication that the person is taking and try to reduce the anticholinergic medication burden, because studies have shown that if you reduce this anticholinergic burden, you can actually improve the cognitive function. And I like to mention that you can access freely to this website, which will help you to calculate the anticholinergic burden of the person that you are actually following, and maybe make changes to the medication to reduce this, the risk of having neurocognitive impairment due to medication. And again, this is an overview of the literature, and you would see that looking at this different cohort of all the people with HIV from all over the world, that the use of medication with anticholinergic properties is quite common, and also inappropriate medication is also very common. So what can we do to prevent polypharmacy and prevent inappropriate prescribing? So I guess the first rule is really to do a medication reconciliation. So ask all the medication, including over-the-counter drugs and drugs like herbals or any other substances that the person is taking. And then I think it's important to periodically review the medication and make sure that all the drugs are still needed, because there is a tendency to give drugs and then leave the individuals on the drugs and not re-question whether or not the person still needs the medication. So you carry on, you increase the amount of drugs over time. And then, of course, verify that the dose is appropriate, knowing that in elderly individuals there is very often, the renal function can be impaired. Of course, verify that there is no inappropriate drugs, and for that you have tools like the BEARS and stop-start criteria that can help you to identify these inappropriate drugs. Of course, verify drug-drug interaction, and when possible, try to switch to unboosted regimen, remove the booster to prevent, to reduce the risk of drug-drug interaction. And I would like also to mention that in the EACTS guidelines, you can find documents, like, for instance, this one that lists the top 10 drug classes to avoid in elderly individuals, or drugs that requires a dose adjustment in individuals with renal impairment. And I would like to mention this study. It's a British study showing that a medication review made by pharmacists, so organizing a special interview with individuals and in front of the pharmacist, and really taking the time to review the medication, can actually help to prevent prescription errors compared to the standard of care where you would review very fast the medication. So it has some beneficial effect. And then I would like also to mention, and I'm sure that Nadia, you know very well this concept, that elderly individuals. So the care of elderly individuals is quite complex. It really requires a multidisciplinary team composed from pharmacists, from geriatricians, from nurses, from ID physician, not only to review the medication and try to modernize the antiretroviral treatment when possible, but also to perform comprehensive geriatric assessments, so to evaluate what are the psychological needs, the functional needs, the need in terms of social health to help with a good aging of the person. And I would like to mention this model from, it's a dedicated HIV geriatric clinic from Chelsea and Westminster, and how they organize it. So basically, there is a phone consultation or a face-to-face outpatient review in the HIV clinic by the physician during the comprehensive geriatric assessment visit. And then if there is issues of polypharmacy, drug-drug interaction, or adherence problem that are identified, then there is a consultation that is organized with the pharmacist. And all the results are then discussed within the multidisciplinary team, and there will be suggestion of treatment changes as needed. If the person has clinical frailty score that is above 5, then there is an additional face-to-face meeting with the multidisciplinary team. But in all cases, all the decisions that are taken and discussed are communicated to the general practitioner of the person, and there are also referrals that are made to specialists. And I'll finish with this case. This is a 69-year-old man who lives with HIV since 2004, obviously well controlled with bictegravir, emtricitabine, and tenofovir alafenamide. He suffers from neurocognitive disorders, depression, gut, gastroesophageal reflux, urticaria, and dyslipidemia, for which he receives hydrochlorothiazide, escitalopram, allopurinol, pantoprazole, clemastine, and atorvastatin. So looking at the laboratory, you can see that the potassium is a bit on the lower end. So the first step when reviewing the prescription is to verify whether, based on the comorbidities, whether there is an indication for all of the drugs that the person is receiving. So in gray, you have the comorbidities and the corresponding co-medication, and you can see that hydrochlorothiazide, so there is not really a need for this diuretic. You can see that the potassium is actually kind of on the lower end. It's as a result of hydrochlorothiazide use. And particularly important is that hydrochlorothiazide can increase uric acid levels. We note that the person has gout, so we don't know if it's induced potentially by this drug. And one potential mechanism is for hydrochlorothiazide to cause a high level of uric acid is that there is a competition at the level of the renal elimination, and also hydrochlorothiazide is recognized as an organic acid and serves as a substrate for moving uric acid intracellularly from renal filtrates. So one potential issue is that the use of hydrochlorothiazide can lead to hyperuricemia and potentially could initiate or could lead to a gout. And if you look in the Liverpool drug-drug interaction website, you can find actually this table where you have what we call this prescribing cascade, and which can occur when a given drugs give a side effect, and then you use another drug to treat this side effect, and these other drugs can induce a side effect, and you will give another drug, and so on and so forth. And you see that thiazide diuretics can cause hyperuricemia and gout, which then can lead to the prescription of allopurinol. So here in this particular situation, maybe the stopping hydrochlorothiazide could potentially resolve the issue of the gout. And then we see that the person suffers from neurocognitive disorders and is receiving clemastine for urticaria. And the issue with clemastine is that this drug has anticholinergic properties and is actually inappropriate for use in elderly people, because it can impair cognition, and particularly there is a risk also in this case of fall, because the patient has also a low blood pressure. So the action would be here to replace clemastine by loratadine, which has not, it is not associated with this anticholinergic adverse effect. And again, I'd like to mention that you can find in the Liverpool drug-drug interaction website this table which lists the top 10 drug classes to avoid in elderly individuals, and you can find the first-generation antihistamine drugs that have these anticholinergic properties and can impair cognition and increase the risk of fall and so on and so forth. And then finally, the last step is to make sure that there are no drug-drug interaction, verify that the doses are appropriate according to, for instance, the renal function of the individuals. And in the particular case, there was no drug-drug interaction between the co-medication and the bictegravir containing regimen. And I'd like to remind you that you can find information on drug-drug interaction in the Liverpool website, but not only, we have a lot of prescribing resources for different kind of issues. For instance, how to administer antiretroviral drugs in case of swallowing difficulties. We have also some document that explains some pharmacological concept. So just invite you to go and look into the prescribing resources square, where you will find lots of documents. I'd like to mention, because we are in Paris, that we have since the summer, a translation in French of the HIV drug interaction website. And then also mention that we have other websites specialized around drug-drug interaction for hepatitis C, COVID, and the clinical case drug-drug interaction website, where you can consult the real-life outcome of drug-drug interaction and also report drug-drug interaction that you would have observed and which could be of interest for, people in the field. So in summary, particular attention is required when prescribing in older people with HIV, as they have a higher number of comorbidities, which can increase the risk of polypharmacy, the risk of drug-drug interaction. There is also age-related physiological changes, which can increase the risk of adverse drug effect. And then, when possible, use unboosted regimen to limit drug-drug interaction with antiretroviral therapy, and importantly, medication reconciliation and a regular review are really essential to prevent, first of all, unnecessary polypharmacy, but also to prevent unwanted adverse outcome, let it be drug-drug interaction or adverse effects. And I would like to thank the colleagues in Switzerland, which participated to some of the work that I showed today, and of course the Liverpool drug-drug interaction. And thank you for your attention.